YouTube channel with a very, very important step. This step has been on my mind for last 2-3 years, that when it comes to MBBS students, we at DAMS are creating a equalization platform for the students, that in any medical college you are studying in MBBS, you have that access to DAMS, where you are at the same level of quality of learning as anybody else in the country. And over the years, I've always felt that something of this sort is needed for residents also. Like in our country, we know all over India, people are doing different courses. Somebody is doing an MD course, somebody is doing a DNB course, somebody is doing a diploma course. And in all those courses, there are so many different parameters. Somebody is in a private hospital, somebody is in a government hospital, somebody has a different set of patient load, some different set of diseases, and there is a need for somebody to help and handhold the students or the residents in their academics as well. And the level of academics throughout the country is again non-uniform. So with this background in mind, we are now in January, we are initiating with our highly esteemed team of medicine faculty members. We are initiating a first step, our first step towards teaching residents in medicine. Like we want to make sure that somebody should be approachable, just like we do in our postgraduate entrance exam or the MBBS levels. Like today we have students from first year MBBS joining us till final year, till internship, till post interns. And same sort of hand holding, I feel, should be done for the residents. That is the intent of our program that we are launching in January. This program would be a live program, which will be available on eMedicoz app. And to give you a sample, in today's session, we will give you a sample of how the teaching would be there for the residents. Now I'll invite Dr. Arvind to speak a few words about the program and what are his thoughts about it.
Thank you, Dr. Sumer, for giving us this opportunity to reach to medical residents. So this program will be filling a gap of clinical art and presenting the case. Because I have seen even during my PG time, it is very easy to read the theory. But when it comes to presentation of the case, then there was a gap. Usually our senior residents, usually our professors, they are busy. So therefore, we are filling that gap and we are conducting this program for clinical cases. So we will be doing 10 to 12 clinical cases, and we as a team will be discussing that clinical case. Also, we will include some classes or seminar by us for a particular case. Before that student will be taking, we will be taking the seminar sort of thing, what points to be asked in history, what is the relevance of those points, and what are the important clinical signs for a particular disease, then how to approach that disease. So that we will be discussing before the clinical case presented by the residents. Now, I would like to invite Dr. Srinath for some words about this course.
Srinath, unmute yourself once.
So it's always been a dream that we conduct a postgraduate level teaching, because I have, through our residency, I have also felt that there is a need for teaching and attend more and more classes. So we as residents have gone from one hospital to other to get a varied approach. Because since in the DNB, we know that it is a national level exam when we give the practical. And 10 years before, there was a massive fear that DNB mein hum pass honge kya. So the quality of DNB exam is so good that you should feel proud when you pass the DNB exam, that you are worthy of that postgraduate degree, and as much as you are when you do your MD also. So in MD hospitals, there may be more patient load, there may be more variety of cases. In DNB hospitals, relatively the patient load and the variety of cases may be less. So this is an attempt to make sure that there is a standardization, and each and every resident has got a chance to make it good in their postgraduate examination. So that's the motive we are all sharing. And I always wanted like pan-India approach in a dream, and that has come almost alive. That we are having a conglomeration of North Indian faculty to South Indian faculty. It's a lovely feeling that the students will get a all-around exposure and all-around growth. Right. So over to Achin sir, and we'll move on further.
Thank you, Srinath and Arvind sir. You have already told the blueprint that we have designed for this particular course, and you'll get an exposure to almost every system that is important for examination in reference to a long case or a clinical discussion. And of course, neurology, if cardiology is the father of all cases, neurology is the mother-in-law, is going to trouble you the most. And as Srinath said, DNB, I still remember, I am myself a DNB medicine, and DNB in my days used to stand for do not bother, or doctoroं के नलायक बच्चे, something like that. But still we cleared it because, you know, there is some lacunae, even in a medical college, even in the MD, sometimes there is some kind of a lacunae which needs to be filled. Hopefully this kind of a course helps to bridge that lacunae and fill it properly, and you pass easily in your exam final. Over to Bharat now.
So thank you very much, sir. So already Sumer sir, Arvind sir, and Srinath sir and Achin sir has given you an idea regarding this course. So I would like to share some views. So after COVID pandemic, now clinical examination has become very difficult especially in our scenario. So this course is usually directed to bridge the gap between that theory clinical examination. So we are faculty. We have seen students and postgraduates throughout the country. So we know what are the questions that they're going to ask you, and especially DNB students, your exam might be at a different center, and you will get a chance to have experiences from all over the country. And I think this is the first kind of this course which is providing resident level teaching. So we have seen so many platforms providing teaching for undergraduate level. So this is one dedicated platform which is going to provide resident level courses. So not just clinical skill, we are also going to organize some seminars so that even your theoretical knowledge will be very well, and even while writing your exams, it will be very helpful. Thank you, sir. Over to Sumer, sir.
I think, thank you all of you for, giving your bit to help students learn. And I feel that is the founding stone of DAMS. Our goal initially when we started DAMS was to create a platform where, no student, just because he's studying in periphery, should be deprived of quality education. That was our initial goal. And gradually with technology, through our satellite initiative, through our mobile app initiative, and recently we've launched live lectures on the eMedicoz app. We want to break those barriers in learning, that anybody anywhere should have access to quality learning and quality teaching, and that is the goal that we would be wanting to fulfill with this course. And before I hand over to the medicine team to start with the first case presentation and first discussion on this in this initiative, which we are sharing live on the YouTube channel, I want to say one line, that we are not going to conduct a conference. I want all the residents who are listening to us to understand the difference. I am one of the first persons in the country who saw that in undergraduate teaching in medical schools, there was a trend towards a presentation, and I wanted to convert that into teaching. And similarly, when I talk about resident teaching, most people have an idea of presentation, like somebody is presenting a didactic thing, which is a monologue. And I want to create a dialogue here. I want to create a system where students are free to learn, they are free to ask, and everybody, in the end of the day, every session will leave you wiser, will leave you, with a feeling that you have learned something more. That is the motto behind this course. I hand over to the medicine faculty to take it forward from it. Thank you, everybody.
I think let's get started. So we have been doing this at college level. Let us take it with our thing. So I'll share screen and I will be, so you can proceed.
Good evening all. So I have chosen a case which was admitted in our medicine ward last month. So I'm starting right now. So it's a 69-year-old female patient, and she's a resident of the female patient Prabhavati English, and she was admitted in our hospital on 1st of last month. And the patient is a resident of Raigad, Maharashtra state, and she's a housewife, and she's staying with her son, and she's a right-handed person, and she's married with 4 children. And she came with complaints of forgetfulness and inability to recognize people, and acute onset headache and irrelevant talks since last 4 days. And the patient was brought by the relative. The history was told by the son. The patient was apparently 4 days back, and according to the relative,
Anand,
yes.
Doctor, just we'll go slow on the chief complaint once more. So,
Yes, sir.
And we have noted the basic personal details of the patient. So, chief complaint where one by one can enumerate please.
She's on the forgetfulness.
Forgetfulness. Okay. So, chief complaint forgetfulness since.
So 4 days. All the symptoms last 4 days, acute onset.
Okay.
And then inability to recognize the people.
Okay. Inability to recognize people. Okay.
Irrelevant talks.
Okay. And all this 4 days.
Yes. And headaches.
And headaches since 4 days. Okay.
Yes.
Right. So, just to put it in perspective, Dr. Achin, Dr. Arvind, how do you put this history up better? Should we put chief complaint, forgetfulness, inability, or just a summary? In a chief complaint, just a summary of altered sensorium, I think would be much better, Doctor? Because
Yes.
if you elaborate on these symptoms, it would be different. So mainly you are looking at a little altered sensorium. So chief complaint, you don't have to describe the character because each of them may have a different localization value. So you can say that patient has come with a altered sensorium, and then we can take it forward as to where is the lesion and so on. What about, yes sir, anybody, is this okay? Altered sensorium since 4 days, headache since 4 days. That is the chief presenting complaint. Right.
I think so. These two are enough to elaborate further discussion.
Okay.
We'll itself.
We can put it as altered sensorium. See, here is in the exam, you will always get a case which may have multiple history. Now the thing is, as a medical graduate, we have to learn to filter the history told by the patient. It can be in patient's own language, but we have to learn to highlight the relevant points. Because unfortunately, the education standards in our country can vary. So the patients also may be from a lower socioeconomic or lower education background, who may give a variety of symptoms, but not all of them may be relevant. Because forgetfulness, usually takes it to a dementia complex, which may not be our final correlating with final diagnosis. So let us try to learn. So the first principle of a clinical case presentation is that in medical college we are taught that you start with the history taking, you start with the personal history, you start with ODP, chief complaint. But I have always believed that we have to start with the diagnosis, because once you, as a student, as a resident, you have taken the whole case. You have the privilege of knowing the final diagnosis. So you must also look back and correlate and reach a better history, because exam is, it's a game. It's an art of presentation is very important. It's a limited time where you have to impress upon the examiner that you have understood the case. So it is not just about enumerating the symptoms. It's also enumerating them in a particular relevant order. So let us put it like that. So altered sensorium and headache since the past 4 days. So should we take some questions on chief complaint, and then we will take it further. Dr. Achin, any questions on chief complaint? So 2 symptoms are there, chief complaint, altered sensorium, headache. Should we
Any?
take questions here?
Yeah, Dr. Anandu, I think so. You need to elaborate these chief complaints now. You'll be talking about it.
That
Yes, sir,
ODP,
in the ODP, then we'll
so do you want to ask any questions on this, or we'll do ODP and then we will?
Yeah, I think so. We'll listen to him fully, then we'll do the dissection work.
So
Okay.
we'll come to the ODP. So let us take one by one symptom you take. So we'll take symptom number 1, altered sensory. So there you can put the description and then we can talk about it more. So elaborate on it. So this is one symptom. Patient has come to you with altered sensorium since 4 days. Yes, go on, doctor.
Sir, I have taken the history as told by the son, and the patient was apparently always 4 days back, and the patient, and he was presenting that these symptoms started immediately after a fight between the relative at home, and the patient relative has noticed that the patient has repeated episode of forgetfulness, which was in sudden onset, and the patient is not able to recognize and remember the immediate thing, whether the patient had breakfast at home or not.
Repeated episodes of forgetfulness. So
Yes,
what
sir.
did the patient relative tell you? Repeated episodes of forgetfulness.
Yes. Sir, actually the patient is not remembering what she had in the breakfast within half an hour, and the patient is not recognizing the people who are staying with the patient since last long time. And sir, patient started talking to herself, and the patient is do not follow the simple oral commands, and she is not able to follow the simple oral commands also.
So forgetfulness is there. There is inability to recognize,
Yes.
and inability to comprehend also. No? You are making the history very different, that you are saying patient is unable to follow simple commands.
Simple command.
So that will become a defect of comprehension. No? Inability to follow simple commands. Okay. And
Sir, and then headache.
so all this is
There's delayed speech and
all this is sudden onset, and is it progress or is it the same from day one? Has there been any recovery or no recovery?
So it was sudden onset, and it is non-progressive, and there is a recovery when the patient got discharged 1 month back. There was a recovery in the during hospital stay in these symptoms also.
So there is some recovery also over the some recovery has started within the past 4 days. It has already started. So why this history is important to ask about the ODP, onset, duration, and progression? Why is it important to know? What does it tell about the course of the disease? So I think let us start with the complaint itself. And the first symptom is altered sensorium. So this altered sensorium, where does it localize the vision? So for all the students, all the residents who are attending, whenever we have a case, whenever we have a medical case, there is a symptom. The questions that we have to answer is, first question should be, where is the disease? Beyond that, you will come to the question, what is the disease? And then you can decide about the how severe is the disease and various causes of the disease. So when you have any symptom in medicine, you have to start by understanding the anatomical localization. That where is the anatomical site of the disease. Then we want to know what is the cause or the pathology. So we want to know what is the disease, etiology, and then we want to look at the severity, because this is going to help identify, plan the management of the patient. So when you take a medicine case, these are the answers that we are looking for. So these should first take. The thing is that there may be multiple symptoms in a patient. After each symptom, you must be able to ask the differential diagnosis. And then you add on the next symptom. So this is what we call a symptom complex. So one symptom has come, you reach a differential. Then you take the second symptom, you add the 2 symptoms and reach a differential. So by the time you add all the symptoms available, you will be able to filter and fine tune and reach the most probable diagnosis. So first question here is, doctor, that when patient has got an altered sensorium, first question, where is the lesion? What is the anatomical localization in this case? So what is the anatomical localization? Most probably, where is the lesion?
Central nervous system. Central nervous systems in the brain and the higher mental functions.
Also very big, no? Where is the lesion? Is central nervous system is large area.
Higher mental functions means
Yeah.
lobar areas, lobar functions will be.
Not lobar area also. See, I tell you. So if you tell me, Anna, can you enumerate the neuro axis? Can you tell me? So this we all know is a neurological case. So can you tell me the neuro axis in neurology? So anatomical localization, we are looking at the neuro axis. So broadly, whenever we take a neurology case, we must be first able to differentiate broadly into two, whether it's a pyramidal problem or whether it is an extrapyramidal problem. Once we know it is a pyramidal problem, then we go on to further whether it is an upper motor neuron or a lower motor neuron disease. And within them, we have got the different levels. So, Anandu, the thing is in upper motor neuron, right from the cortex. So, whether it is cortex, whether it is internal capsule, whether it is the brainstem. So, whether it is cortex, internal capsule, brainstem, we want to know. Whether it is the spinal cord, whether it is the spinal cord, whether it is anterior horn cell, whether it is going to be the peripheral nerve, whether it is going to be the neuromuscular junction, or whether it is going to be the muscle. So first of all, now always train yourself that where is the lesion. So first, when we say this is a neurology case, the first step you have to take is to identify whether it is pyramidal, extrapyramidal. Now, extrapyramidal, please remember, typically presents with involuntary movements. So, involuntary movements and defect of tone is related to the extrapyramidal disease. Classical example being Parkinson's and Parkinsonism complexes. So, this will go away. So in our case, where the sensorium is affected, obviously it is a pyramidal problem. But within the pyramidal problem, out of these 8 areas, you have to give me one area. You don't have to go to the lobe directly. First, you have to tell me where is the lesion. So sometimes the symptom can be at various levels. So you will have to tell me the extent. So it can be from cortex to the spinal cord. So suppose there is a case of hemiplegia. Hemiplegia can be anywhere between cortex and spinal cord, like that. So in this patient, you have got a symptom altered sensorium. So if altered sensorium is there, what is the medical name and where is the lesion? You will see. Among these areas, where is the lesion? Altered sensorium. Another name, altered sensorium, what to call? Medical language में क्या बोलते हैं? You call it encephalopathy, no? Encephalon is what? Encephalon. The other name is called. So patient is having a cortical involvement. Please remember, higher mental function cannot be at any other level. Higher mental function is directly localizing you to the cortex. Then we can go into details about where within the cortex. So here only we are learning how to organize our history. So you have got a constellation of symptoms from the patient. But unless you can arrange it in a manner which will make medical sense, you will find yourself trapped in your history. You will find yourself more confused rather than wiser. So try to accommodate and filter it out. So हम क्या करेंगे? First you summarize. So first there is altered sensorium, big picture. So patient has altered sensorium means there is encephalon. Encephalopathy means it is a cortical problem. Within the cortex, then you have to look at the various lobes. And then you can look at the what is the reason. Okay. So here we are looking at within the cortex, how to localize within the lobes of the cortex. So we know within the lobes of the cortex, we can have the frontal lobe, we can have the parietal lobe, we can have the temporal and the occipital. Temporal or the occipital. So then I want you all to enumerate. So we can start with our anybody. We can start, anybody can volunteer. So just can you enumerate for me what will be the presenting symptoms depending on the lobe? Give me a summary. What will be the presenting symptom depending on the lobe? You can also start with Anandu. So start with maybe frontal lobe, and any one of you can volunteer the answers for others. So enumerate the symptoms. So first we must have knowledge. Then only we can apply that in the case and fit it together. Come on, go for it. Frontal lobe symptom.
Some personality changes, some mood changes, and emotional disturbance.
Okay, so personality, emotional ability. Okay.
Loss of inhibition.
Loss of inhibition, right? Emotional ability. Can you tell me what is frontal lobe bladder? Anybody? What is a frontal lobe bladder? Anybody? What do you mean by a frontal lobe bladder? Okay. Let's first enumerate other symptoms. Tell me, parietal lobe symptom. So these questions are the 4 things which every examiner is going to ask you, irrespective of where you give the exam. You have a patient of neurology for sure in our final exam. So if when you get a question and you say altered sensorium, these questions are bound to come. Encephalopathy, enumerate to me symptoms of each lobe, and this should be absolutely free flow from all of you. This is the absolute necessity that we have to put it. Everybody, Achin and Arvind sir, do you agree? These are basic questions which are expected in our exams.
Yes, because in, I think so, neurology, localization is the only keyword, and it is more clinical than radiological localization at the end. So
yeah, and it is also very important to look for the negative history as well. If this history was present or absent, and that examiner will like to listen why this history is important. So whether it is a positive or negative history, both histories are very important.
So unless you know all the symptoms, Anandu, how are you going to establish? So you have put in these symptoms here. So today is just a learning session that if you say forgetfulness, where do you place this forgetfulness? Think about it. Where would you place this forgetfulness? Where would you?
To memory. It's memory. So parietal lobe.
Where is the memory center? So can you describe the memory pathway? Can you describe the memory pathway? Anybody?
Types.
Memory pathway, how does it come to? What is the short-term memory, long-term memory, conversion? So you are putting it in memory. Where does it go to? So I'm just trying to point out, Anandu, here is that this history should be conveniently excluded. Anna, you are looking, what is your final diagnosis? Has got nothing to do with dementia. No? So if it has got nothing to do with dementia, I think you should at least try to, speak about this symptom very quietly. Anna, everybody of us will agree, I think, that exam is that art. My professor used to always say, Anna, exam does not tell you how much you know. Anna, exam tells, if you pass, it tells you, you know how much you have to know. So you have to learn that some history may look very tempting to include, but it's going to take you far away. Anna, this unable to recognize these questions, history which are there. Now you try to put it for me. That what is your diagnosis? Give me your final diagnosis.
So, diagnosed as 16-year-old female patient who presented with a history of altered sensorium and headaches and photos. And by the history wise, I have my professional diagnosis, it may be some vascular causes, maybe ischemic or hemorrhagic, affecting the higher mental functions of the brain. That means the upper motor neuron of the brain.
We discussed here that first of all, first what you have to give me, you have to give me the functional diagnosis. Then you have to give me the anatomical localization. Then you have to give me the etiology or the pathological diagnosis. Then you have to tell me whether there is a complication. And then you have to tell me whether there are any associated disease, whether there are other not associated, unassociated disorders are also present in this patient. So unless you can organize, see, because I have seen that many examiners in a postgraduate presentation, you start presenting the history. But if you're listen to me carefully, many times the examiner has not seen your patient personally. The examiner does not know about the patient personally. So the examiner is trying to visualize the case through your words. So when you start giving a history and the examiner is unable to identify clearly what is the problem, immediately the next question they put in front of you is, okay, doctor, tell me the history. So when they ask you history, you must understand that your history has not conveyed clearly to what is the diagnosis, because then they are confused that what am I hearing and what am I expecting. So I'm trying to counter check by asking. So like today, I don't know, none of us know the case that you're presenting. So we are looking at it unbiased. So we are asking you history and the diagnosis. So what diagnosis are you putting it as? Functional diagnosis? What do you say is the altered sensory? So functional diagnosis is the altered sensory. But here medical word we must use is encephalopathy. So this encephalopathy is there, which is obviously in the cortex. But what is the lesion? So this altered sensorium is due to the encephalopathy, cortical lesion. So cortical lesion which is acute onset. Please remember, in neurology, it is very simple. Acute pathology can be trauma, vascular, infective or demyelinating. So you have to choose considering the age of the patient. See, every point you should be able to justify. Even if it is wrong, you must be able to justify your answer. So you must say that most probably it is vascular, considering the age of the patient and also the recovery. You are considering most probably vascular. Now, what can be the complications of a stroke? So if it is a hemiplegia or something, or whether it is brainstem, you are looking at acute complication of aspiration pneumonia and all. So these are the viva questions, complications of stroke and any unassociated disease. So whether patient has other problem like anemia, patient elderly female might have osteoporosis. So those come in that picture. So here again I'm little stuck with the history, the detailing that you have done, that we are looking at a encephalopathy, which is probably vascular. But where is the lesion? It still remains a little unclear. So again I'm telling you, this is not a bad way to look at it. The good way to look at it is, many times history may be confusing, but then at least the viva, the theory concepts must be very clear to you to ensure that you sail through. So you only tell me that how do you assess each of these symptoms. Arvind sir, you can ask what more questions you want to ask about these individual symptoms.
Anando, first of all, I think so you should not, as Srinath said, don't put forgetfulness somewhere in the beginning part. Just mention it beneath, because the moment you say something related to memory, and I know the female elderly somewhere, even nearing 60, they think about dementia more of a common disorder. Secondly, inability to recognize faces or objects, and inability to follow simple command. They should always come on the beginning part. And as you rightly said, sudden onset. Now, something we like to negate at this point. Did she hear some bad news, or there was some bereavement in the family? Because somewhere we find in our clinical practice hysteria. that needs to be always ruled out in your presenting complaint. So in a negative history, any bad news or bereavement in the family or any emotional episode happened before this event should always be taken into care. Second, I always feel like history of fever. Was it there or not? Because the moment you say altered sensorium, first thing in my mind comes is encephalitis. But since it is a sudden onset, obviously will not keep there, but history of fever should always be there. Then since you have told headache also in the presenting complaint, then you need to elaborate what kind of headache was it? Was it throbbing, dull aching, stabbing? And of course, was it
the second symptom? So Anandu just has to finish this much is the only symptom that you have asked in the history about altered sensorium, or is there more points? So these symptoms you have said sudden onset with some recovery. Have you asked any more history about this?
So in the positive history phase, I got the patient was also complaining of instability while walking, so swaying on the side while walking.
Okay. So patient also had a difficult impaired gait problem. Okay. And see, you are asked just bits and pieces, no? We'll have to go into a little detail at PG level. We are expecting a little more characteristic of what you are describing. Just by saying, you know, difficulty in walking would have been okay to scrape through in undergraduate level. But here we'll have to go into the little detail of these symptoms. So any negative history have you asked? Like sir has asked about fever and any emotion, trauma.
Yes, sir. There is no, in the negative history part I have asked, there is no history of any fever, vomiting, there is any weakness of the limbs. That means in the proximal weakness, I have asked whether the patient has inability to get up from the starting position or unable to comb her hair. And for the sensory symptoms, sir, I have asked there is no feeling heat and cold while taking bath, or there is no tingling numbness of the extremities or nothing. And then in the involuntary movements, I asked there is no history of any involuntary movements, and there is for the bladder disturbance, I asked if the patient is feeling the sensation of the bladder and she is able to initiate the micturition, and she is able to control the micturition once the micturition has occurred, and there is complete evacuation also, sir. And there is no history of inability to pass the urine, and there is no history of any constipation, loose stools. And for the cranial nerve negative history, I have ruled out there is no loss of sensation, there is no history of difficulty in vision.
Okay, so let us do that. So for the benefit of all the students listening to you, why don't you enumerate one by one, starting from the first cranial nerve, the negative history that you asked about cranial nerve. Cranial nerve, what history have you asked for?
For the first one, it's an olfactory. So whether the patient is able to sense the smell of food, very familiar objects.
I know what is the symptom, but I want you to just enumerate what you have asked about this. Suppose first cranial nerve. So just enumerate. So even if you have not written, now presently, in live time, you just enumerate in order, imagine it, visualize in your mind and tell me symptom, how to exclude cranial nerve involvement. What symptom will you ask? Don't tell me the physiology. Okay, you have to now tell me the answer, what I'm asking. This symptom, enumerate. What have you asked for first cranial nerve? What did you say? No history of?
The patient is able to recognize the smell of the food. And,
medical, no history of what you have asked. So there is no history of what?
Losses.
Okay, loss of smell. Okay, further then. Come on, everybody can participate. I think these are all UG, PG, everything is the same only. Further, next.
For the second optic nerve, for the difficulty in vision or the difficulty in reaching the objects or something.
Okay. Further.
For next, sir, for the fifth cranial nerve, I asked any tingling, numbness over the face, or difficulty in chewing, difficulty in having food.
Okay.
Go with third, fourth, sixth like this. No, ask there is no history of double vision
Double vision. So
or any dropping of eyelid. Like go in a sequence, it will be easy. No, there's no history of ptosis, diplopia done.
Yes, no.
So third, fourth, sixth we have almost done. Fifth, you are telling me there is no difficulty in chewing the food.
Chewing the food.
Okay, and there is no loss of sensation on the face. That goes with the fifth. Okay, seventh. What will you ask for seventh?
So there is no history of any dribbling of saliva, or there is no history of any facial asymmetry, visible facial asymmetry.
Okay.
Or any
taste also of food.
Taste also.
Yeah, that's again a very common initial complaint sometime by facial nerve palsy, the choroidal Panny branch. Okay, we are done with 7th. Now, how will you ask about the 8th? 8th cranial nerve.
So any fullness or voice in the ear, tinnitus.
No, that will be a very local middle ear problem. You're telling me. We'll ask for any vertigo. Since your patient had a difficulty in maintaining the balance, so again the 8th nerve comes into the play. Na? Was there any history of giddiness as a symptom? Vertigo is more clinical term. Okay, right. Then will 9th, 10th, all the bulbar muscles. How will you ask about the 10th and the 9th?
So, there is any hoarseness of voice, or there is any difficulty in deglutition, dysphagia.
Okay. Any change in speech also will go into the 12th dysarthria.
Yes, sir.
Okay.
Okay, continue. Achin, take over. Further, more questions.
I think so. This much is sufficient because we have touched about all the cranial nerves. Because sometimes, if you have a 3rd, 4th, 6th, then you can think about the midbrain, and depending on that. Okay. And now in symptoms, one negative history, I think so, Dr. Anandu, we need to ask is any history of head trauma. Head trauma prior to these symptoms, because being an elderly patient, again, trauma, SDH, you know, can present with any kind of a symptom like this. So since the symptoms were acute, we need to always think about any history of trauma. Okay. And since the symptoms were always vascular, so again, we need to think about and ruling it out. Then
I would like to add this altered sensorium or encephalopathy, we will also think of metabolic causes, because from the history, what I can judge, there is no hemiplegia, no aphasia or nothing like that. So we will also think of whether it was acute onset of some hepatic problem or electrolyte imbalance, especially in elderly. Hyponatremia is a cause of acute altered sensorium, especially if patient is hypertensive on diuretic, thiazide diuretics. So that can also lead to. So we will also look for negative history of any metabolic cause, which could be hepatic, uremic, or electrolyte imbalance. And of course, any drug intake history, which can lead to these metabolic causes.
Then how will you ask about, Anandu, about the metabolic, like sir said? One by one, you can tell us about encephalopathy. We can think about the common ones first. Hepatic encaph. Obviously, prior to this, there is going to be loss of appetite. There is going to be yellowish discolorization of sclera and high-colored urine. Yes.
Yes.
And was the patient in the past history? Obviously, you will take that. Was the patient taking any kind of a drug? Maybe a hypertensive thiazide diuretic, which can precipitate hyponatremia very quickly. And most important, we need to always look into the patient, like before all these symptoms, was the eating normal or not? Was there any disorder in eating by the patient? Because that will always point towards a metabolic event, right?
Yes, sir.
Should we elaborate on the second symptom before we go on to examination? So you tell about headache. So what is about headache that you have asked?
Headache also, it's an acute onset, non-progressive, bifrontal, mild. So, she's presenting like aching type of headache with no history of any vomiting. There is no history of any blurring of vision. Supposedly.
Is this, we need to also ask Dr. Anando on this, that
Correct.
is this the first time she's experiencing this kind of headache, or was there a previous also? It means like it's acute on chronic kind of a headache, or it's a acute episode in the past history?
Sure.
Because in female, you know, tension headache is fairly common. 60 plus, please remember, we need to look into if it is a temporal or anywhere, we need to rule out temporal arteritis in them. Okay. So once you tell something like headache, you need to always suspect some serious causes, like Dr. Shinaz said. Yes, we need to look out for serious causes, like it can be an intracranial space occupying lesion. One. Second, it could be a brain hemorrhage, a hemorrhagic stroke. Okay, which can be extracranial as well, right? So we can think about space occupying lesion, hemorrhage, then we can think about inflammatory disorders like temporal arteritis, right?
Yes.
So Viva is yours. All of you, there are many, quite a few of you. Come on, bring out some causes. Tell me what are the serious, suspect the serious causes. In headache, what history must you ask which will suggest any serious cause? Come on.
Subarachnoid hemorrhage, sir. The worst ever headache.
Very good. So is it the worst ever headache? Very good. More. Very good. Worst ever. Then what are these symptoms that you are asking for? Blurring of vision, projectile vomiting,
Intracranial.
Raised intracranial tension. Very good. Yes. Raised ICT. What else? What else? Come on. That's the correct one. Associated with what? So headache, which is sudden onset, associated with features of raised ICT, worst ever, or associated with what all will suggest a serious cause. Think and tell me, no, if it is a hemorrhagic stroke or an SOL, along with headache, what will happen? What else also will be there?
Blood pressure.
Suppose there is a, come on, others also participate. If there is a, suppose I am saying there is a putamen, basal ganglia bleed, and a hypertensive bleed. What else? What kind of thing will you get? Presentation. You will get a hemiplegia, no? You can get
focal neurological deficit.
So associated with focal neurological deficit, associated with fever, because it could be infective, inflammatory cause. And so we must know, associated with features of meningism. Come on, enumerate me features of meningism.
So it will be also the neck rigidity, restriction of neck movement, altered sensory.
Fever.
Right. So your history is a part where we can work on a lot. We have to work on a lot. That I told you, I'm keeping telling you in every case that what we have to do, you have to take history till you can have a probable answer. See, unfortunately, there is no line that what is the negative history. You have to keep asking questions till you can justify the probable cause of that symptom. You have to keep asking more and more. So that will come only with practice. More you ask, then you filter. First, you have to create a massive database. Because very limited symptoms will give you very limited answers. I'm again telling you, even if sometimes the patient's history may be unreliable, no examiner will fail you because you have not taken much history. But you must be able to then answer the Viva questions very fluently. But if you have not able to get the history or not taken a history, and you also falter in Viva, then the chances of us going through become lesser and lesser. So we have to look at, these are no common symptoms, no? altered sensorium, headache are all common symptoms, which causes must be extremely rapid. These are rapid fire questions. No, don't waste time, because in all the university exams, in case you will get clearly, you will get 10 minutes for the history, 10 minutes you will get for the examination, 10 minutes for the management and diagnosis. So you have to be very, very sharp in answering. So, right. So go on.
So then,
Further, go on to exam. So should we proceed to examination? So we have got a differential. Probable diagnosis is there is encephalopathy, which could be either a cerebrovascular accident or metabolic. So let us see if examination holds any clue.
Just a question, Dr. Anandu. Why cannot we call it as a space-occupying lesion since 69 age? Elderlies are more prone to have brain tumors than we can have. Why should we not think as this as a space-occupying lesion? Tell me. Since we have a deficit in that cortical area, we have got headache also. Why not space-occupying lesion? I think so, Dr. Anandu video has got stuck. Yeah.
sir, that's sir, now I can hear you.
Yeah. Why don't we keep this case as a case of a brain tumor, space-occupying lesion? Why not that? Think and tell me.
So there is no definite focal neurological deficit we didn't get in history.
Okay.
And, there is an acute onset, sir. There is an acute onset, for example.
Right. Fine. What do brain tumors more commonly present to you with? You must have seen patients, no? What do brain tumor patients commonly present with? One is headache. Second, don't forget seizure. Okay. Since there is no history of convulsion or seizure in the past, we negate space-occupying lesion at this point. Okay. Yes. Right. Since you told headache, that's why I'm asking you about that. But still, we are stuck somewhere. Where is the lesion? Because cortex is a big area. Now, I think so. Clinical examination will help us somewhere. Right. We are still not clear. Is it a diffuse or a localized kind of a thing? Right. I think so. You go ahead with a clinical examination.
The clinical examination, sir, is starting with the patient is moderately built, moderately nourished, and the patient is sitting comfortably in the bed. And in the head-to-toe examination, sir, there is no pallor, there is no clubbing, there is no cyanosis, there is no icterus, there is no palpable lymph nodes, there is no edema of feet, there is no signs of raised JVP, and her spine looks normal, and there is in skin also there is no hypopigmentation or hyperpigmented patches. There is no thickened nerves we could see. And in the vital section, sir, the patient's temperature, the patient was febrile. Pulse rate is around 72 beats per minute, regular. And the radial artery felt like a thick cord-like structure, and with BP of 130/84, and respiratory rate was 16 cycles per minute. The GP, that's all.
So, Dr. Anandu, are we any wiser on general physical examination in this case?
Excuse me, sir?
Anything extra? Do we have something abnormal in this case?
Sir, no, sir. On the palpation of the artery, there was some atherosclerotic change which could correlate some vascular process later on.
Okay.
And nothing else. There's no carotid bruit. Nothing.
That's what I want to ask. No carotid bruit is there.
Nothing. Sir.
Okay. Arvind sir, anything N or GP will like to add? Something? Because this is something more important than systemic.
Jaundice aspect, whether there was jaundice or not.
Icterus, sir.
No, sir. No icterus.
And any skin signs of uremia? No skin signs of uremia. All right.
No,
So
sir, no.
we can go
It's only
for
hyperpigmentation. So scratch marks or nothing.
No, nothing like that. Like uremic frost, scratch marks, ecchymosis. So nothing like that, no? Okay.
No,
So
sir.
I think we can go for the systemic examination now.
Yes, sir. So the patient is on central nervous examination. And the first one, higher functions. And the patient is conscious. And the patient is disoriented to both all the time, place, and person. And there is an abnormal behavior present. The memory couldn't check. The patient was not responding to simple commands also. There is no delusion, hallucination. The speech, the patient has fluency. The speech is normal, sir. And then comes the cranial nerve examinations. So can I proceed with the cranial nerve examination?
How did you assess for speech in a disoriented patient? I want to know this, because patient, like,
So actually, the patient disoriented, but the patient is able to talk. So the fluency and the speech, and there is no
No. See, in the chief complaint you told us, na, she was unable to follow commands. So comprehension ka to gaya.
Yeah.
So be careful once you say disoriented. Very cautiously tell about the speech. Either you say, sir, patient was very agitated, could not follow my commands. So one thing is gone, comprehension is lost. Okay. So further things like naming, repetition, obviously they are lost. Then you go to the fluency part. Was she talking or not? Were the words comprehensible to you or not? Or was there any kind of a neologistic speech? Okay. Because you need to rule out psychiatric problems also at this point. Okay, so you can just say, sir, comprehension was not appropriate because she was disoriented. So I could not test about the rhyming and the repetition, but her spontaneous speech was there without any new word formation or neologism. So I think so that should be fine. Okay, so in one word, you can just put the speech part out. Cranial nerve.
The cranial nerve examination, sir. The first.
Cranial nerve is normal. Just tell me what are the positive findings that you got.
So actually, because of this loss of comprehension, we could do the limited test for the cranial nerve examination. Like,
that's okay.
And those, no, sir, those are positive only, sir. We didn't get anything finding in the cranial nerve examination.
Okay, well, cranial nerve next. Motor system normal.
So motor system, the motor system, she was not following the command, but there is the nutrition we have checked. The nutrition we have checked, sir, and it is normal, and there's bulk of the muscle is normal, power is normal, the patient is able to walk also, tone also normal, the reflexes are normal.
Any positive findings? Have you found any positive findings other than disorientation, or there is no focal deficit per se?
So there is no focal deficit as per the motor examination.
So there is no focal neurological deficit. There is only disorientation is the only finding on your clinical examination.
Clinical examination.
Okay. Just enumerate what are the respiratory complications of stroke. Enumerate what are the respiratory complications of stroke.
Respiratory aspiration for the bedridden patients.
Okay.
Loss of gag reflex also causes the aspiration.
Okay.
Second one, for the bedridden patient, pneumonia is okay. And the brainstem involvement, there is the patient can go to respiratory arrest also. If there is respiratory centers are affected.
Yes.
Is there any special type of breathing in these patients? So you are telling that if brainstem is involved, medulla oblongata is involved, is there any type of breathing that can happen in this patient? Yes.
So Kussmaul you will get in brainstem.
Kussmauls generally we get when there is some metabolic acidosis. So it is rapid and deep breathing. So here your brainstem medulla oblongata directly respiratory center is affected, which usually takes care of the rhythm of the breathing. So what might happen? Yes. So you know what is Biot's breathing? Yes. Biot's breathing, ataxic breathing. So all these are specific type of breathing where there will be some clusters of breathing will be there, apneas will be there. So it is different from Cheyne-Stokes breathing where you will have a periodic breathing, waxing, waning apnea. But in Biot's breathing, so initially there can be some deep breaths, so then there can be apnea, some rapid deep breaths and apnea. So if it is still progressing, it can go into ataxic breathing, which is characterized by irregular breathing with irregular apneas. So this all will happen whenever there is some stroke involving brainstem, which is causing some problem in the medulla oblongata.
Yes. Great. Go on. So tell me what further, any other system examination, any significant findings, or we'll proceed to the diagnosis then?
So on the cerebellar examination, there is a the patient was patient couldn't just walk in the straight line that and she was swaying to both sides tandemly. The gait was not normal. It was not localized to one area, sir, one side.
Right. So what is your final diagnosis now?
So there is a 69-year-old female patient presented with the altered sensorium. Patient presented with the altered sensorium and probably affecting the cortical area of the brain due to some vascular causes. And there is no complication associated with it.
But why are you so sure that it is vascular? Why not metabolic? There has been no focal neurological deficit whatsoever. So why not metabolic, which is known to be fluctuating and which will recover in a fast time also? Since you are saying that patient improved during the course of the admission, it is possible that it could be metabolic also. Now, with such acute recovery, you will have to give a differential. So what you will say that encephalopathy, whether it is query metabolic, query vascular, because there is a limitation to clinical medicine. Clinical medicine cannot confirm. There may be a component of both also. So, idea is to give a more differential diagnosis is important rather than getting a fixed diagnosis. Because in the management part, you will be able to enumerate what test you want to do so that we can understand it better. So keep your differential open, don't close it like that. So, in this short time, it is also not possible to exclude infection as a matter of fact. So, can you name some infections which present as altered sensorium?
Japanese encephalitis, viral infections.
Viral.
Measles also sometimes complications.
Measles. But more common in the monsoon time, what infections occur which can come with altered sensorium? Infections with thrombocytopenia and altered sensorium. Suppose this patient has got thrombocytopenia. So what would be your differential diagnosis?
Viral fevers like dengue, chikungunya.
Dengue can be there. Very good. Malaria, cerebral malaria, possible.
Yes. Yes, please.
How will you manage the patient?
So first on the routine investigation we will proceed.
Okay. Okay. Enumerate. Anandu, there is nothing called routine investigation.
Yes, sir, complete hemograms. There is.
Before the exam, I'm telling you what we practice, yes, what we will present in the end also. So let's start.
Yes,
so complete blood count.
So renal function test and liver function test, and so lipid profiles, ECG. Then comes the imaging techniques.
Let us take this patient has got a metabolic problem. Let us see what would be the test that you are wanting to do. What metabolic tests are you excluding? So kidney problem, liver problem. What else do you want to exclude? Come on, what is the biggest? India is what capital of the world?
Diabetics.
What test do you want to do for diabetes?
Sugars, blood sugars.
Okay. And any more metabolic cause? So you have taken care of uremia, hepatic, blood sugar. What else?
Ammonia, sir. Ammonia we can. Okay, that's LFT.
So with liver, I'll put ammonia. Very good. What else? Suppose there is a patient with metabolic encephalopathy. What test you must do? So renal, liver function with ammonia, blood sugar level. What else?
So hypoxia, ABG should be done. Arterial blood gases.
Very good. Very good. So ABG. So hypoventilation, CO2 narcosis. We must definitely look at those probabilities. For vascular cause, what would you like to do? For vascular cause, what you want to do?
Go for imaging techniques.
Clear to say, I would like to do neuroimaging. Which neuroimaging would you prefer, CT or MRI? Imaging would you like to?
So MRI should be done if it is an earlier stage if you want to diagnose CT.
So in this patient, which one would you prefer? Suppose this patient has come to the casualty, altered sensorium since 4 days, headache since 4 days. What would you like to do first in the emergency department?
So of course CT will be the first choice. It will roll out the hemorrhagic infarct.
Very good. But for detailed, is the ideal you would like to go MRI. So do you have any reports of this patient that you are discussing? Do you have any diagnosis made based on the report?
Yes, sir. The patient reports of frontoparietal infarct in the MRI reports.
To be having a frontoparietal infarct. Okay.
The patient is a known case of diabetic hypertension.
Okay. So patient is a known case of diabetes, hypertension, and was found to have a vascular infarct. But again, let me warn you that even though in the exam, even though you know the patient that it is vascular, this is the common mistake you can do in the exam. Because in the exam, you don't have a CT scan or a MRI report. So I would still go with the first differential as metabolic. I think that is a big point, that if we just based on the history that you have given, with no focal neurological deficits whatsoever, to suspect that small cortical infarct is uncommon. No? More common, I think we should go for metabolic. Which is there is fine. That is retrospective diagnosis or investigation based. But based on the history, I think more favors metabolic disease. So please remember, and I still remember in the exam, when I gave my final exam, there was a case of just a simple, there was hepatomegaly. It was a short case, so we were not even allowed to take history that time. We had to just present the case. So the thing was, it was a tender hepatomegaly. That's all. So thing is that many students, the examiner asked the first question, what is your diagnosis? Their answer was, it is congestive hepatomegaly, CCF. Because it was the own case of cor pulmonale. That same case was given as COPD to some students. But the thing was that examiner just used to nod their head. So it came to my turn. The thing was, I had to just say, I would like to give the differential of tender hepatomegaly. Once the term was mentioned only, the examiner was happy that this is done. So this is important not to get biased. Even if somebody tells you the diagnosis, go take the infarct case. Do not please be biased that it is infarct only. You have to be able to justify based on what available history and available examination. What about, yes sir? Don't we agree? We are not having the privilege of test and we cannot comment that it is vascular. We should go with statistically common things first.
Yes.
Infarct, how would you treat the patient? Suppose this is an infarct. What treatment would you like to offer the patient?
Antiplatelets, anticoagulants. If it,
So you want to give antiplatelet, you want to give anticoagulant also.
so not anticoagulants, sir, antiplatelets, right?
So you want to give antiplatelet, and so which antiplatelet you want to give? Dual, single, triple? Now it is not the time. You have to be specific. You have to tell me name of the drug, the dose, the route of administration. I would like to start the one.
Sir, dual antiplatelets, aspirin and
Dual antiplatelet. Achin sir, Arvind sir, dual antiplatelet. Are you sure dual antiplatelet?
Yeah, this is still matter of debate actually. Only one drug, aspirin, is more than sufficient as per the recent guidelines if you go with the HA also. And Dr. Anandu, please remember,
Yes.
once you say I don't want to give anticoagulant, you have to justify. Why? If you must have heard about this CHAT2 score. Look at your patient. She is 69. So I believe her age is less than 75. So she did not get any point for that. But yeah, the second is she is a diabetic patient. So she get +1 score for that.
Yes.
Okay. And I think so hypertension also comes in, if I'm not wrong.
Yes,
So
yes.
yeah, so if you exceed the score, then you might require an anticoagulant. So once you say I don't want to give anticoagulant, you need to know the scoring system also.
I think we should ask others also. Ashish, and Jyoti and Vinod. Can you enumerate me indications of anticoagulation in stroke? Enumerate for me indications of anticoagulation in stroke.
Non-hemorrhagic stroke.
Which kind of stroke, what other thing would you give anticoagulation? Come on, 1, 2 answers, 1, 2 conditions.
Some valvular heart disease, just a hint. Think about it.
Atrial fibrillation.
Okay.
Okay. Come on. Only one. Come on, yaar. Itna so thoda bahut to naam bachao. Let us give little more answer. Anticoagulation in stroke. What are the indications? 1, 2, 3, 4. अरे गिनाओ मेरे को.
DVT causing. DVT.
In DVT, you give anticoagulation to prevent pulmonary embolism, maybe.
Yes.
Yeah,
Carrot.
not preventing.
Carotid thrombosis.
Carotid.
But that for that, I think so more of endarterectomy or stenting is required, not this.
Chalo. So we have to cover all these points. So moral of the story of the exercise is that when you present a case of stroke, the cases may vary, but the questions are going to be repetitive. So these are the same things that are going to come back to you, which you must be ready with. These are common questions, right till the management of the patient that we must be extremely fluent with, so that we can get through the viva of the patient. The examination, what are your areas you feel that you would benefit in a postgraduate level exam? Where do you think you will need help or guidance? You have spent 2 years, everybody goes through residency. Where do you think you need the guidance? It's not that you are all not working. We are all working, you are seeing patients, you are studying. But the thing is that effective studying is not happening. We are all putting in lot of effort. But unless there is a reward, output also should be equivalent. No? So, I think organizing the questions, organizing the history, repeated case presentation is required, no doubt about it, to make it a habit. So you have to know what is the final target and reach. So from others, from first years and all, I would like to know that where would you like to the help to come mainly. Anand, you can start, and Jyoti and Vinod can also add to the point that what kind of help as a PG resident are you looking at? What kind of guidance are you looking at?
So if you are approaching any clinical cases while taking the history, we get diverted somewhere. So actually, we are inability to come to a focus on diagnosis in the professional in a history basis. And then comes the examination. There is a proper procedures, and we should be lacking sometimes. And we will be get confused with this between the reflexes, where is hyper, and those things. And then in the management part also we are lacking of the recent advances and what is happening in the recently in the management part also. We feel something difficult to answer in the investigation part also. Which investigation we should tell this examiner to tell first, which should be the next and which should be the next. And if you say the MRI brain at the beginning and it will go somewhere else. So these things will be.
It's a matter of practice, and most important to present the cases to a variety of systems. Vinod Kumar, Jyoti, what are your comments? Where you feel guidance will help as a PG resident? So suppose you start in the first year, what are the kind of guidance would you benefit from?
Sir, basics in history taking.
History taking.
Yes. How to go about the history and initial management. If a patient is in like stroke, comes to a casualty, the basics initial management, like the first step, what are we supposed to do? If now I have got a call in casualty, I have come, there is a patient with breathlessness. So the CMO is telling it can be a DKA. So what all investigation should I send for diabetic ketoacidosis? Initial management, I have to act fast to manage the patient. So about the initial management things, what all signs I should look clinically, how to manage the patient.
I think emergencies, we must all consider making a small video, maybe one session on emergencies, common emergencies, maybe few we can put like that. Just I'm trying to get an overview that how we can make the course more effective and compact yet effective, that it will cover more and more points for the students. Right. Okay. So, sir, all your comments, otherwise we'll close this. What?
I think so. So you say Arvind sir.
Yeah, I think two important things which needs more and more practice is the good clinical history taking, and we will devote more time to the clinical history. Why this history, why not this history, so that we can elaborate more and more. So we will devote almost 50% time on the history. And the second part which I can judge is the management part. So what we can do, the management new guidelines like the stroke guidelines or any DKA guidelines or an emergency guidelines, so that we can discuss beforehand. So that management part, new guidelines, because students are busy in their clinical duties, they are not able to attend the conferences or these updates, so that we can put from our side. So this is my point of view.
Yes, agreed, sir, because a lot of work is required from our end also, and active participation from the student end as well. Because I still remember in my days, I never had any good teacher whom I could go and present a case, because no one was willing to listen to me. So one of my senior told me, you stand in front of a mirror and present it to yourself. At least फेंकने में, बोलने में, you'll be confident ना. बाकी तो गलत बोले तो कोई बात नहीं. That's excusable. That's pardoned actually. Because I still remember I went for my final DNB exam, and there was one candidate from a good hospital where the result of DNB was good, and he was totally confused in general physical examination. So things like journal physical examination, the whole performer should be by heart with you. You should not miss anything in it. And above all, history taking is an art which you learn. The more you take, the more you learn. See, don't think ever in your hospital you're going to get classical cases. Classical cases, even in a medical colleges nowadays, are rare. They all come with a very subtle kind of a symptom from which you need to pick out the whole disease. And then you go back and see the patient, you'll find everything which is written in the book on the patient itself. So I'll suggest you don't neglect any patient that you see in the ward, stroke, anything. Just go and take a history, make it a habit, because you've got 10 or 15 cases which are going to come at the end. So if you are through and through those history taking, I think so there should not be any problem at all. Bharat?
Sir, postgraduate teaching especially is very extensive, and it is a daunting task for all of our faculty. But one thing what we like to promise you is we'll try to compile the required things so that you can face any examiner and any exam without any fear. See, the problem nowadays that I see with my postgraduates is they are having the knowledge, so they don't know where to apply it, how to answer to the questions. So this interactive classes, our target is, so not just imparting you the knowledge, we'll also make sure that you are applying it correctly. So not just in the clinical practice, not just in the exams, see wherever it is required. So that will be the main motto of this program.
Yes. Okay. So thank you, everyone. I think thank you, Anandu. That's a good start. We'll keep building on as we present more and more cases. We'll become better. I want all, more participation. All of you, let me assure you, by not participating, we are never going to learn. We should rather give wrong answers. One wrong answer and the examiner corrects you, that answer is remembered for life. So I think that's the need of the hour.
And best thing today, after a long time, I saw people using the ceiling fan. Okay, Arvind sir, Sumer sir. In Mumbai, look at the temperature. They're wearing half sleeves. Look at us, wearing full sweater, inner, everything. Such a contrast.
So in the end, I thought, I'd summarize that in this program, what will happen is this is going to be a short live course on eMedicoz that we are starting in the first project. This would have two parts. There will be sessions with didactic teaching, where the faculty members will be teaching, and there will be sessions with presentations, where there will be a presenting volunteer from the course itself, and the faculty will moderate and teach interactively like we have done today. So to the best of my knowledge, this is one of its kind course, and we will be launching the course soon on the eMedicoz app. Go to the eMedicoz app in the live courses section, select the resident courses, and you will find the medicine course. I wish you all the best. Thank you to the entire faculty team for joining in.